Rehabilitation in the Older Adult. It's brought to you by the Dakota Geriatrics Program, which is funded by HRSA. The goals for this presentation include understanding a framework for making people more capable and independent. It's also looking at options for rehabilitation, including the setting for rehab. We want to talk about assistive devices and some environmental modifications that can enhance independence in the community, and then finally give some specific examples of stroke and orthopedic rehab. If we look at the framework for rehabilitation, the World Health Organization has an excellent construction here where they divide rehabilitation into a functional consideration and addressing the disability, and then on the other hand, considering simultaneously the contextual factors such as what is the environment and what is the psychosocial elements such as motivation. So we can see this where if we focus on just the function, there might be some gains in strength and mobility, but if we don't think about the contextual framework, there could be potential offsets that prevent rehabilitation. So specific examples might include a family that does everything for the person under rehab, or that there may not be enough attention paid to alteration in the physical environment. The sites of rehab of care may make a difference. So hospital-based care involves an interprofessional team. The skilled nursing facility is the more generic site for rehabilitation. Both of these are funded by Medicare A as a benefit. Clinic-based orders for both outpatient rehab and for home health can be generated with a multi-team approach. The site of rehab may make a difference, particularly in cerebral vascular accidents, and so stroke rehabs are best in an inpatient setting. The literature and medical evidence is not as strong for hip fracture being conducted at one particular place, and so both the inpatient and skilled nursing facility could be fairly similar in their outcomes, with the exception of the highly medically complex patient who may benefit from inpatient settings. Take a look at the interprofessional team. The physical therapist, we consider the individual that helps bring back strength, particularly in the lower extremities for transfers, gait, and mobility, to gain additional independence, or to use an assistive device that will help in mobility. The occupational therapist, on the other hand, tends to be the individual that addresses deficits in ADL and IADLs, as well as issues with cognition and vision, generally the fine motor skills. And then the rest of the team members are listed here with their particular focus. We have other members of the interprofessional team, such as the nurses, which actually execute the plan for ADL and self-care skills. The CNAs, certified nurse assistants, assist the nurses in that process. We have speech therapists, and then finally the team is overseen by the primary care provider, whether that be a physician, nurse practitioner, or a physician's assistant. We need to really think about prevention as we enter into the rehab process. Avoidance of iatrogenic diseases such as nosocomial infections or medication errors. Falls are prevalent in rehab settings, and that's because people are deconditioned and weak. Pressure ulcers are potentially avoidable, although 20% of pressure ulcers may not be avoidable. And there's a variety of reasons that people get pressure ulcers. And as can be seen here, the sacral ulcer is really difficult to heal. Social isolation and loneliness can be a big problem, and it's one of those mitigating factors in preventing people from gaining full functional independence, as well as issues related to urinary and bowel incontinence. and then also to avoid aspiration, particularly in those individuals that are later on in their years or have recovered from a stroke. In terms of stroke rehab in particular, a third of the individuals have very severe deficits. And generally, these might range from hemiplegia, if your body is paralyzed, dysphagia, aphasia, visual problems, and cognitive impairments. The trajectory of recovery is slowed and less potential for recovery the more of those problems that you have as a result of stroke. There's additional risk factors for post-stroke spasticity of the muscles, which can be painful and cause contractions. We already mentioned about pressure ulcers, and then finally seizures, which, by the way, older adults with memory disorders, particularly Alzheimer's, can also develop de novo seizures. The rehab goals for stroke are to, of course, try to maximize functional independence in the activities of daily living. We want to consider the psychosocial elements about coping and about promoting adaptation. We also want to prevent recurrent stroke. And then overall, we want to assist the individual with reentry into the community setting as best possible. The stroke rehab trajectories can be viewed here in just kind of a general context, but basically the first month is where most of the gains are made in post-stroke recovery. There's about a 3-month window overall for the vast majority, 90% of the stroke recovery. Thereafter, there's just small incremental changes, and then you have the whole issue offsetting here, as you can see in the graph, normal age changes in deconditioning that may occur since we lose 1% of muscle mass per year after the age of 60. It might be well to use the NIH stroke severity scale to help the team understand both the likelihood of recovery and the extent of interventions needed. The earlier that the interventions are implemented, the higher the likelihood of a return to home. So there's some specific techniques in stroke rehab that can be considered. One is to restrict or constrain the good limb, so that if you have hemiparesis, that it forces the individual to use the so-called bad limb or the affected limb. You can use, as seen in the picture here, a harness treadmill to help the person enhance their lower extremity movement. Mirror therapy is something where you use a mirror to look at the good side while practicing with your bad side. And you can also use mirror therapy in amputation rehabilitation. And there's a variety of other things, such as magnetic therapy for dysphagia and electrical stimulation, and a variety of other techniques which still have yet to be fully proven beneficial. In terms of the orthopedic realm, hip fractures are the bane of the older adult. High mortality, 5% during hospitalization, and a quarter of the people will die within 1 year. Early weight bearing after hip repair improves outcomes, and the more intense the rehab, the better the outcomes. And as I mentioned, the geriatric collaboration with the orthopedist is a geri ortho unit, has improved outcomes and patient satisfaction. So that's a fairly new model of medical care. In terms of orthopedic rehab, we need to consider deep vein thrombosis prophylaxis, so using enoxaparin or its equivalent for at least 14 days after a procedure. Again, like stroke, early mobilization is critical, as is addressing pain management. And it turns out that individuals with a hip arthroplasty or a new hip, if they're over the age of 70 and if they have 2 chronic conditions or more, that they would benefit most from an inpatient setting for rehab. Adaptive equipment is important to consider, and so looking at a raised toilet seat, or here you can see in the lower picture the shower chair or bench, as well as prescribing a bedside commode for the person under rehab. Some specific considerations about amputees. They tend to have a high mortality, particularly those with diabetes and vascular compromise. It's important that any type of rehabilitation have some pre-procedure, what we call prehab or prehabilitation. The importance of preserving the amputee with a below-the-knee amputation because it takes more strength and energy if you have an above-the-knee amputation for ambulation. Phantom pain is really highly prevalent, and again, we can use mirror therapy to reduce that, and there's some medications that are partially successful in reducing, if not eliminating, limb phantom pain. There are chronic disease rehab programs, so pulmonary rehab, cardiovascular rehab. The underlying principle of these is that strength training or resistance training increases the muscle mitochondrial density, and that improves oxygen uptake and utilization, thus reducing fatigue and weakness. Also want to point out that if the individual has problems ambulating, or if they're wheelchair bound, that upper extremity exercise is equivalent to lower extremity exercise for generalized benefit and endurance. We need to consider mobility devices. Straight cane typically is used in osteoarthritis and or neuropathies. And there's a variety of other assistive devices, and I want to make a comment about the power wheelchair here. So just some tidbits in terms of use of the cane. It's always used in the opposite side of the affected limb for osteoarthritis. And then the top of the cane should come at wrist level high with the arms dropped at the side of the patient. In terms of power chairs and scooters, oh boy, those things can really accelerate deconditioning, and they're to be avoided as much as possible. Not surprisingly, CMS doesn't pay for these unless you meet a variety of criteria. They could be important and valuable for end-stage conditions such as heart failure and COPD, but otherwise in early stages of chronic conditions, not so much. And then the power chairs or scooters might be good for bilateral arm weakness, such as you might see in multiple sclerosis or Lou Gehrig's disease. So I'd like to summarize by saying that reactivation should always be sooner rather than later for optimal outcomes. It should be team-based, and that's the best approach. You want to address both the function and the contextual factors simultaneously so that you can motivate the individual and bring their social support system to help influence positively their adaptation and advancement towards independence. Always remember that strength training through resistance or weights can help build the muscle mitochondrial load, and that improves endurance and reduces fatigue. Always be mindful of pain as a barrier to recovery, particularly in the aphasic or cognitively impaired patient who may not be able to express themselves and may have visual expressions of pain as opposed to verbal. And then finally, always be an advocate for fall and stroke prevention. And with that, I appreciate your attention, and I look forward to reviewing some of the other micro lectures that we have in this series.